Thanks for the introduction, and thank you all for joining me today and for the opportunity to speak with you about my research program. So as Michelle pointed out, I've been an assistant professor in the Social and Administrative Sciences Division at the School of Pharmacy since 2014, so actually 6 years. You gave me one extra year. But before that, I received both my Doctor of Pharmacy degree and my PhD degrees from UW-Madison. So as Michelle pointed out, the Badger pride runs deep. And today I'll be talking a little bit broadly about my research program, about the various projects I've been involved in, as well as diving a little bit more in depth on some of the projects I've been involved in, just to give you a little bit more detail. And so, we're living in a time of unprecedented change in healthcare in the United States, and we're seeing major changes to the way that healthcare is financed, structured, and delivered. And policymakers are grappling with ways to ensure that our health policies are being crafted in a way that ensure adequate patient access to healthcare while balancing the quality and the value of this care. And this is a particularly challenging endeavor for publicly funded programs that are serving vulnerable populations, such as state Medicaid programs that cover low-income and disabled individuals, or programs like the federal Medicare program for older adults. And although policymakers are currently dealing with some pressing public health issues that have created additional challenges for our healthcare system, through rigorous research of existing policies, this presents opportunities for new and innovative solutions to meet the changing healthcare needs of our country. And so my career goal is to produce rigorous health policy relevant research that can be used to improve the structure and function of the U.S. healthcare system. And my research is aimed at identifying ways to improve the three primary goals of the U.S. healthcare system: access to healthcare, the affordability of healthcare, and the quality of healthcare. To accomplish these aims, my research is concentrated in the following key areas: evaluating the effectiveness of health policies and programs, identifying potential solutions to emerging public health issues, and improving the health and welfare of vulnerable rural and low-income populations. And my research is very multidisciplinary as it uses principles, methods, and theoretical frameworks from a variety of disciplines, including from my home department of the Social and Administrative Sciences and Pharmacy, but also things like population health, epidemiology, health economics, and public affairs. And my approach to research is unique because it looks at contemporary health policy issues in the U.S. healthcare system through a pharmacy lens. I was trained as a pharmacist, and that sticks with me in how I approach my research. And this is a perspective that has not commonly been adopted in the past in the health policy world. And this approach is really useful to understand those complex interrelationships between the utilization and costs of prescription drugs, healthcare services, and patient health outcomes. So why would we be interested in the evaluation of health policies and programs? International comparisons between different health systems are an important way to see how healthcare in your country compares to others. And these comparisons are typically based on the cost, access, and quality of care that is available to citizens of these countries. And as you can see from the figure here, the U.S. healthcare system ranks last among developed countries. The U.S. ranks lowest on a number of dimensions, such as access, efficiency, equity, healthy lives, and costs. People in the U.S. go without needed health care because of cost more often than people do in other countries, as we remain the only developed country in the world without universal coverage. And as a result, there are major health disparities in the U.S., as many Americans do not receive care or skip taking their medications when they're needed because of costs. There are also significant disparities related to race, income, and where someone lives. The U.S. also ranks poorly on measures of quality. We're ranked worse in the worst in the world in preventable deaths and infant mortality, and second worst in healthy life expectancy. Our death rates from preventable conditions are 25 to 50% higher than some countries. The U.S. is also a major outlier when it comes to healthcare costs. We spend approximately 2 to 3 times more on healthcare than other countries, and we also pay significantly more for prescription drugs. So based on these data, there are a lot of opportunities to improve the structure and functioning of the U.S. healthcare system, both at the federal or the national level, as well as at the state level here in Wisconsin. And one way to do this is by evaluating the effectiveness of health policies and programs. Just to define health policy, this is a broad term that the World Health Organization defines as decisions, plans, and actions that are undertaken to achieve specific healthcare goals within a society. And as I said, it's a very broad term that encompasses a lot of things. So health policies may try to improve population health by targeting health behaviors such as tobacco use or vaccinations. They may target the organization of healthcare or payment to healthcare facilities, health systems, and healthcare providers. They may also target insurers by requiring coverage for services such as prescription drugs or mental health care. And policies may also try to improve health equity by addressing disparities, such as providing support to critical access hospitals or providers in medically underserved areas. However, there's a strong need for rigorous evidence to inform and educate policymakers in order to improve the effectiveness of health policies, as well as for evidence to inform the design and operation of health programs in order to improve our main goal, which is to improve the health of patients. So my research program utilizes principles of what's known as program evaluation to evaluate the impact of health policies and programs. And program evaluation is a systematic method for collecting, analyzing, and using information about the effectiveness and efficiency of projects, policies, and programs with the eventual goals of generating evidence of the impact of a program on outcomes such as member health, program costs, identifying areas for improvement, and so on. And just to give you a sense of my research, it's primarily conducted using what is known as secondary claims data analysis. In other words, I obtain data on paid healthcare claims from health insurers, health systems, pharmacies, or surveys, which then provide objective information on what is occurring in the US healthcare system. What sort of use of healthcare are we seeing? What sort of costs are we seeing? And these data often contain information from thousands or even millions of patients, which really allows us to get a comprehensive look at patient behaviors. And this gives us confidence that what we're observing is accurately reflecting what is truly happening in the US healthcare system. My primary focus of my research is evaluating the impact of changes to insurance coverage and cost containment policies on access to and the affordability of prescription drugs and related healthcare services. And my objectives are to identify whether health policies and programs are producing their desired goals or outcomes, and to identify opportunities to improve their effectiveness and efficiency. And my work in this area has evaluated the impact of policies and programs that seek to expand access to health insurance coverage, to increase access to healthcare services, and to reduce healthcare costs and improve patient outcomes. So my own work in health policy and program evaluation has primarily been in the areas shown here. My research team has conducted several studies looking at the impact of several provisions from the Patient Protection and Affordable Care Act, or the ACA, including things like the young adult insurance expansion, the contraceptive coverage mandate, and more recent provisions closing the Medicare Part D coverage gap. I'm also involved in research with a group of health economists and health services researchers to evaluate the impact of changes to Wisconsin's Medicaid program in areas such as access and utilization of anti-diabetic drugs and increasing coverage for mental health and substance abuse services through what are known as mental health parity laws. I'm also collaborating with a team of researchers from around the country to identify new ways to utilize and support pharmacists in combating the opioid epidemic. And some of my more recent work has focused on what's known as the Wisconsin Senior Care Program, as well as the federal Medicare program, which I'll talk about a little bit more later in the presentation. But now I'd like to take a few minutes to focus a little bit more in depth on some of these projects to provide some more detail about the research gaps that they address, how the research was conducted, and some of the important implications of these findings. So the first project I'd like to discuss is some of my work at the federal or national policy level, evaluating provisions of the Affordable Care Act. And my work in this area was the first to comprehensively assess the impact of several ACA provisions on pharmacy-related outcomes, and this study was the first to investigate the policy's impact on rural-urban disparities in insurance coverage. So this study was an evaluation of what was known as the dependent coverage mandate. And what this policy was it extended the age of eligibility to allow young adults to remain on their parents' insurance plan until the age of 26, regardless of marital status, residency, financial dependency, or anything else, really. And the goal of this policy was to improve access to insurance coverage and healthcare services. And the motivation for this policy was that prior to the implementation of it, nearly a third of young adults lacked any health insurance coverage. When I was this age, the standard was that when you turned 18, you were kicked off of your parents' insurance coverage. And so this policy extended that out to the age of 26, which from initial evaluations of this policy, it was very promising. We saw large decreases in the number of uninsured young adults after the first year, as more people were able to stay on their parents' health insurance longer. But although this policy was having its intended effect of increasing health insurance coverage rates among young adults, there were also some questions that were emerging about whether the policy was having a disproportionate impact on certain subpopulations. For example, there were several studies that found variable impacts of the policy on various racial or ethnic groups. But there was no evidence on how this policy impacted rural-urban disparities in insurance coverage, which was of particular significance given the large disparities that exist in insurance coverage for rural populations. Residents of rural areas are more likely to be uninsured, and they have less access to private health insurance than their urban counterparts. As a result, this often leads to higher out-of-pocket costs and greater financial burden from healthcare. And because of these factors, the Rural Healthy People 2020 guidelines identified access to quality health services as the single most important rural health priority. And so the purpose of this study was to evaluate the impact of this policy, the Affordable Care Act's dependent coverage mandate, on disparities in insurance coverage among young adults in urban and rural areas. So this study used data over a 5-year period that were obtained from the Medical Expenditure Panel Survey. And this is a really great survey that contains a rich amount of data on things like insurance coverage, healthcare utilization, and patient perceptions for a nationally representative sample of adults in the US. And what we did was we conducted a pre-post evaluation of this policy, so what happened before and after the policy was passed, and we utilized something known as a difference in differences design. And this approach has allowed us to compare the trends in insurance coverage between two groups. Our treatment group of young adults that were aged 19 to 25 that were the target of this policy, and then we used a comparison group of slightly older adults that were aged 27 to 34 years. And this comparison group was selected because they overlap close, they're not that much different than the 19 to 25-year-old group, and they overlap in key socioeconomic indicators and their health status, but their eligibility for insurance coverage was unaffected by this ACA mandate. And we excluded individuals that were at that cutoff age of 26, as they would only be eligible for partial year coverage before they turned 26 and were no longer eligible to stay on their parents' insurance. Now, the difference in differences study design is a really powerful program evaluation tool that controls for secular trends in order to identify the impact of a policy. That is, it rules out other potential explanations for why other changes that may have occurred during that time frame. It accounts for that and allows us to identify and isolate the true impact of the policy. And this approach also allows us to control for other factors that may impact health insurance coverage rates, such as income, education, health status, and so on. And then we took our analysis and we stratified our models by residence area, which allowed us to then compare changes in insurance coverage between urban and rural areas to see if the policy had an impact on these rural-urban disparities. So our data contained information on about 11,000 young adults and about 13,000 individuals in our older cohort of adults. And because of the structure of the survey, we're able to generalize our findings to the true population of young adults in the country, which is about 47 million young adults. So a really powerful data source. And of note, I want to point out that about 85% of the population in the US lived in urban areas compared to about 15% of rural areas. So this is primarily among those young adults and this cohort of slightly older adults. Obviously, the distribution of the population is going to be a little bit different once you start looking at older age groups, such as older adults who are 65 and older. So the figure on this slide shows how annual trends in private health insurance coverage changed between the two groups before and after the policy. From the line at the top of the figure, I'm not sure if you can see my mouse on the screen or not, you can see that approximately 2/3 of adults in the older cohort had private insurance each year, which remained constant before and after implementation of the ACA mandate. And again, this makes sense because this group was not impacted by the policy. They were over 26, and so they were not eligible to stay on their parents' insurance. In contrast, you can see the line on the bottom that shows that only about 1/2 of young adults had full year insurance coverage before the ACA mandate went into effect. And then there was this rapid increase of about 10 percentage points that was seen immediately following implementation of the policy. And I do want to clarify that this is full year health insurance coverage. And we chose this outcome, which means that they had insurance coverage for all 12 months of the year because, sort of thinking about the difference between statistical significance and clinical significance, it's not particularly meaningful if a young adult gains 1 month of insurance coverage in a year. We really want to see that these individuals were able to maintain some continuity in their coverage throughout the entire year. So I've simplified the main findings for the purposes of this presentation, but the results from our fully adjusted difference in differences analysis are shown here, which indicated that overall, there was a 9.2 percentage point increase in private health insurance coverage among young adults relative to the comparison group following the ACA mandate. And when these models were stratified by area of residence, we found an increase in urban areas of 9.0 percentage points compared to 10.1 percentage points in rural areas. So although there was a slightly larger increase in rural areas, when we did some statistical testing, these increases were not significantly different from one another. So we can conclude that although there was a very positive impact of this policy, leading to large increases in private health insurance coverage among young adults generally, the policy really had no meaningful impact on rural-urban disparities in insurance coverage. In addition, we also found that even after the policy was implemented, about 1/3 of young adults were still lacking full-year health insurance coverage, which suggested the need for additional policies to address the high rate of uninsured young adults. We conducted some additional analyses looking at the issue in different ways to rule out other potential explanations or conclusions for these findings, which adds some confidence that what we found is the true result. Now I'd like to shift gears a little bit to focus on my work in health policy and program evaluation at the state level, so the state of Wisconsin. And my research in this area evaluates the impact of changes to insurance coverage in publicly funded health insurance programs here in Wisconsin and aims to improve medication access and affordability. The second project I'd like to talk about in more detail was an evaluation of changes to the Wisconsin Medicaid program. And this project was conducted in collaboration with my colleagues, Dr. Nam-Yo Kim at the UW School of Pharmacy and Dr. Marguerite Burns at the UW Department of Population Health Sciences. And this study was published in Health Affairs, which is one of the highest impact health policy journals in the country. So it really received a lot of interest and attention. First is some background context. The Wisconsin Medicaid program provides health insurance coverage for vulnerable low-income and disabled individuals in the state. Here in Wisconsin, we like to give things snazzy names, so it's also referred to as Badger Care Plus. It would not be a Wisconsin program if it didn't have the word Badger in it, right? And it's an important source of health insurance in the state as it covers about 1 million Wisconsin residents, and about half of the enrollees are children. But there are two other important groups that I'm going to talk about in more detail in the context of this study. So I'm going to be talking about parents or caretakers, also known as adults with children. And I'm also going to talk about childless adults or adults without children. So our Medicaid program is structured such that there are relatively low out-of-pocket costs for healthcare, which is reflective of the limited ability for these individuals to pay for these costs. But it's important to recognize that there are variable benefits and out-of-pocket costs depending on various eligibility criteria that are set each year. So the study I'm going to discuss is an evaluation of changes to the Wisconsin Medicaid program that became effective on April 1st, 2014. And this change primarily affected childless adults with very low income. To give you some context of what this less than 100% of the federal poverty level number means, this income level is equivalent to a yearly income of less than $17,000 for an individual, or less than $35,000 for a family of four. So before the program changed, there was limited coverage that was provided to childless adults. There were caps on enrollment, which led to large wait lists due to high demand for this coverage. Childless adults were also enrolled in what was known as the core plan, which provided less comprehensive coverage and had higher out-of-pocket costs than the standard plan, which was available to parents and caretakers. After the program changed, these enrollment caps were removed, and all childless adults that met this income criterion were now able to enroll in the program. Importantly, all childless adults that previously received the limited coverage through the core plan were then transitioned to the standard plan, which now provided more comprehensive coverage and lower costs that were equivalent to what was being provided to those parents and caretakers. So in case my verbal description was a bit confusing, here's a quick visual of the program change that occurred. And you can see that our treatment group of childless adults on the top transitioned from this limited core plan to the more generous standard plan, whereas our comparison group of parents and caretakers remained in the more generous standard plan in both time periods. So again, another powerful tool that lets us take advantage of the fact that we had a group that was impacted by the policy and a group that was not. So this leads me to the research gap for this study. And the program change I just described resulted in a couple of benefits. First, it resulted in a drug formulary expansion, and it led to copayment reductions, resulting in more generous coverage for prescription drugs for childless adults in the state. But previous research that's available in the literature has focused almost exclusively on drug coverage restrictions, such as putting limits on drug coverage or increasing out-of-pocket costs. So this study was really unique and informative because it was the first to evaluate expanded drug coverage in a state Medicaid program. This study is particularly important as low-income childless adults are a very vulnerable group with high health needs that often go unmet because traditionally they're ineligible for Medicaid coverage, and as a result, they're often uninsured or have limited health insurance benefits. And even in this study, we saw that the childless adults enrolled in that core plan had limited coverage before the policy change. There's also a big lack of literature on this population, which still leaves a lot of questions about how we can best address their unmet health needs. So the objective of this study was to evaluate the impact of the 2014 Wisconsin Medicaid drug coverage expansion on anti-diabetic drug use and out-of-pocket spending. I'll talk about why we focused on diabetes in just a moment. So this study used data on over 20,000 enrollees in the Wisconsin Medicaid program, or the Badger Care program. And we selected individuals with type 2 diabetes for a couple of reasons, but mainly because it's a highly prevalent chronic disease in the US, and there are cost-effective prescription drug treatments that are available, which are very important for managing the health of these patients. And the program change acted as what's known as a natural experiment here in the state of Wisconsin, which provided the opportunity to conduct a rigorous program evaluation. We again used a difference in differences design to take advantage of the fact that we had information on both the childless adults that experienced this expansion in drug coverage and a comparison group of parents and caretakers that maintained consistent coverage throughout the study period. Now, this analysis was a little bit more complex than the previous one, as we had to make several statistical adjustments to account for the distributions of the outcome variables. But I'm not going to bore you with some of those details, but I'm happy to talk more about that later. And we utilized data for a period that included 1 full year before and 1 full year after the effective date of the drug coverage expansion to see what the impact was. And our first primary outcome that we looked at was the change in drug utilization, which was measured as the change in the mean annual number of 30-day prescription drug fills per person. Our second primary outcome was the change in drug expenditures or drug costs, which was measured as the change in mean annual out-of-pocket drug spending per person. So how much were these individuals having to pay for their prescription drugs? Shown here in this figure are the trends in monthly out-of-pocket spending on anti-diabetic drugs in the two groups. And you can see the childless adult group is shown here in kind of an orangish color, and the comparison group of parents and caretakers is shown in blue. And you can see that the out-of-pocket spending in the blue line, the parents and caretakers, remained essentially unchanged throughout the study period, as again, they were unaffected by the program change. But I think you can also probably very quickly tell when the program change went into effect and what the impact of this program change was, as there was a significant drop in out-of-pocket spending among the childless adults. From our fully adjusted regression models, we found that the drug coverage expansion was associated with a small but significant increase in anti-diabetic drug use among the childless adults relative to those parents and caretakers. But sort of looking at it in more detail, it was noteworthy that the odds of using any anti-diabetic drug increased by 24%. And what this means is that there was a large influx of new drug users, people who had not used drug before the policy, but were now using drugs after the program change became effective. And this means that there was likely unmet need among people who had been diagnosed with diabetes but were previously being untreated for this condition. We also saw significant increases in the use of brand name prescription drugs, which are particularly expensive but are vital to diabetes treatment, given the increasing number of new treatments that have become available in recent years. We also found that the drug coverage expansion resulted in a huge decrease in annual patient out-of-pocket spending by a whopping 70%, 70%. And this finding was seen across all therapeutic classes, but the largest impact was seen for some really important medications such as insulin. So the findings from the study indicated that the expansion in drug coverage resulted in both increased utilization and greatly decreased spending on anti-diabetic medications. And our findings were indicative of unmet need that among these childless adults that was at least partly addressed by the program change, but likely there may have been other unmet needs that still needed to be addressed.
Kevin, can I ask a quick question on the slide?
Sure.
We saw a slight increase in drug fills, even though there was a 24% increase in patients using the drugs. I don't quite understand how that worked.
Sure. So if you just sort of pool everyone together in one big group, overall you saw this increase of 4%. But what we did was we broke out the population to look separately at people who were sort of new initiators of drugs and people who had already been using drugs, because those are two different populations, right? If someone's already taking 3 or 4 medications and now, they may have already had their health needs met before the program change went into effect. And essentially what we saw was those people were still using the same drugs after the program change went into effect. So people who were already using drugs were essentially unaffected by this program change. But where we did see a big increase, and that's why these numbers are a little bit different, because you're kind of, by pooling these two groups together, you sort of wash out the effect a little bit. But again, among people who were using no drugs before the program change, suddenly we saw a huge increase in the amount of drugs that they were using. And sort of through the other analyses that we did and the review of the literature and evidence that's out there, it looked like a lot of these people may not have been able to afford their drugs before the program change. And due to the formulary expansion and the changes in out-of-pocket costs, they could now afford to get those vital medications that they didn't have access to before the policy change. Does that answer your question, Steve?
Thanks, Kevin. That clears it up.
Not a problem. Thanks. So in some of our related work, we've been building upon this to continue to look in more detail at this program change. For example, Dr. Kim published a paper this past year that found that the drug coverage expansion was also associated with improved medication adherence, as well as significant improvements in the quality of drug use among diabetic patients. So not just meaningless increases in drug use, but very meaningful, important increases in medication use among this childless adult population. And these findings are particularly important to some of the current health policy discussions that are going on now, as many states have already opted to or are considering expanding their Medicaid programs to cover more of these childless adults through the Affordable Care Act Medicaid expansion policies, including here in the state of Wisconsin. There's been discussion about that as well. And the findings from this study that was conducted here in Wisconsin can then inform the impact of such expansions on the health of childless adults across the country. So really cool stuff. Some of my recent work has expanded my focus on evaluating the impact of health policies and programs on vulnerable low-income populations, including some recent collaborations with colleagues at the UW Department of Population Health Sciences and the UW Institute for Research on Poverty, that was the first to evaluate the implementation of national policies that required parity in coverage for mental health and substance use disorder services within Medicaid programs. And these projects have led to some additional external funding opportunities to further investigate these and related topics, including an RO3 grant proposal submission to the National Institute on Drug Abuse to study more in depth the treatment of opioid use disorder within the Wisconsin State Medicaid program. And I'm also involved as a site investigator for an R34 grant that's also funded by the National Institute on Drug Abuse. That's a multi-state study of pharmacist involvement in addressing the opioid epidemic and meeting the unmet needs of these vulnerable patients. These projects have also led to my involvement in the evaluation of something that I referred to earlier called the Wisconsin Senior Care Program, which is a drug assistance benefit for low-income seniors here in the state of Wisconsin. And this initiative is funded through a 5-year contract with the Wisconsin Department of Health Services and the Federal Centers for Medicare and Medicaid Services, and we will be utilizing health and drug claims data on millions of older adults enrolled in the Wisconsin Senior Care, the Wisconsin Medicaid, and the federal or national Medicare programs. And this provides a really exciting and very unique opportunity for us to comprehensively evaluate not only the impact of the senior care program on the health of seniors here in Wisconsin, but it also allows us to then apply the lessons learned from the experiences of older adults here in our state to improve the health of older adults around the country that are enrolled in other programs such as the Medicare Part D program. And our evaluation team is housed in the UW School of Pharmacy and the UW Institute for Research on Poverty. And I want to recognize, although this is led by myself, it's provided with the support of Dr. Kim here in the School of Pharmacy and in collaboration with experts in health economics, public health insurance programs, and health policy. So I want to thank you very much for your time and attention today. A very special thank you for the support from the faculty, staff, and graduate students, both in the SAS division, as well as the support of all of you throughout the UW School of Pharmacy, as well as the support of my colleagues in the UW Institute for Research on Poverty and the UW Department of Population Health Sciences, as well as the members of my mentoring committee and all of the other organizations that have supported me.